basically nak tahu dulu apa management pasal nephrotic syndrome ni, first thing first kena tahu dululah apa beza nephritic dengan nephrotic syndrome. So think topik ni medical student basically memang kena tahulah nephrotic itu apa, nephritic itu apa, features of nephritic and features of nephrotic are very different lah. So nephrotic is basically massive proteinuria, so causing edema lah. So edema in nephrotic will be very obvious, but edema in nephritic is very mild. Okay, so on top of it, nephrotic syndrome juga features dia ada hypoalbuminemia, so kena albumin less than 25. On top of it ada hypercholesterolemia jugalah. So kalau management tu, one of it you hantar cholesterol level jugalah. But the most important thing investigation you kena hantar is urine protein creatinine index or urine PCI, the early morning urine PCI. Kalau more than 200 mg per millimole, that's basically proteinuric range of proteinuria lah. Memang you confirm is nephrotic syndrome. So once you fulfill all the 4 diagnoses, that's easy to diagnose nephrotic syndrome lah. While nephritic dia ada features lain lah, which is the main features other than mild edema is the hematuria. So hematuria in can be macroscopic, can be microscopic lah. So on top of it there is some exothymia, a bit of AKI and all that. Urea may be increased. The other features is hypertension lah. So in nephrotic, kalau ada hypertension, is could be despite the urine proteinuria in a nephrotic range, that one is atypical features of nephrotic syndrome. That's why you have to investigate lah the secondary cause. So kalau cakap pasal cause of in nephrotic syndrome, most of the cause nephrotic syndrome in children is idiopathic nephrotic syndrome. Another thing we call it minimal change disease lah. Kalau kita buat renal biopsy, 90% of these children ada minimal change lah, meaning dekat only can be seen dekat electron microscopy. You buat the renal biopsy, you put under the electron microscopy dekat nephron tu, dekat podocyte dia, with diffuse dia tak ada typical podocyte, normal podocyte, so that one causing the leakage lah, so causing the proteinuria. 90% is minimal change disease lah. That's why they say it's minimal change, but you tengok dekat normal microscope, you tak nampak apa-apa abnormal dekat nephron tu, but once you tengok dekat electron microscopic, baru you nampak that minimal change punya changes dekat podocyte lah. Okay, so the investigation you hantar typical ABC, RP, electrolyte, send urine PCI, send urine FME daily jugalah. So you boleh hantar 24 hours urine protein, but this one very susah lah ya, pakai 24 hours urine collection. So most of the time we prefer to hantar you punya urine PCI, you boleh hantar you punya cholesterol level jugalah basically. So another thing you hantar kalau you suspect this one is atypical, you might want to work out for SLE, you might want to work out any, could be post-rep acute glomerulonephritis juga lah. Some of them very have a proteinuric nephrotic range of proteinuria lah, so it is a secondary cause of nephrotic syndrome as well. Okay, so renal biopsy not really indicated because most of the time it is minimal change disease, unless there are the features like renal impairment, there are the features of hypertension, and then also the gross hematuria. That one memang kena buat renal biopsy. Okay, so kalau features nephrotic syndrome already diagnosed, the first thing you want to manage is basically you continue the normal protein diet, start the antibiotics lah you want to cover for your streptococcal infection. You most of the time you give IV CPAN kalau to cover for any ongoing infection at the time, or you can start your PENV as well. PENV ikut umur. PENV prophylaxis is BD dose lah, not the QID dose, the typical treatment dose if pakai PENV. So ikut umur, the dose basically ikut umur lah, either 1 to 5 mg, 250 mg or 500 mg BD. Okay, so we don't really fluid restrict in nephrotic syndrome. We just continue the standard requirement, the normal maintenance daily untuk children lah. So the important thing is to watch out lah. Certain budak basically ada hypovolemia or hypovolemic shock lah. So kalau hypovolemia datang dengan abdominal pain, and then ada cold refrains, poor capillary refill, and then ada low blood pressure lah. Then kalau hypovolemia, you may have the crepitation, ada rongkai, ada hypertension and hepatosplenomegaly. Okay, so kalau patient yang datang dengan massive proteinuria, dia punya ascites is very bad, the scrotal edema as well, we kind of like keen to bagi the albumin 20% with furosemide, just to help control the edema. And on top of it, we also start the treatment of penicillin and all that while waiting for the induction penicillin to take effect. So most of the time we want to keep the edema under control, because when they have massive ascites, massive scrotal edema can cause discomfort as well to the children. So we try to control the edema by giving IV albumin 20% or 35% lah. So most of the time is 20%. Depends on what availability of albumin dekat dalam ward tu lah. So we give IV albumin together with furosemide lah. Some we give midway of albumin infusion, some give midway and at the end of albumin infusion lah, just to the reason behind it. You give midway, then at the end when you give albumin infusion, you can like withdraw the water from the intracellular. Once you already withdraw the water you go into the intravascular, you give furosemide to flush the excess fluid out. Okay, so you can help with edema, but in the end the induction with penicillin is the one helping with the proteinuria. Once the less leaking happen, may have more albumin, all this will cause fluid shift lah from intracellular to intravascular. Okay, but caution when you give albumin is basically kalau patient has hypertension, you don't give albumin, you may cause pulmonary edema lah, because BP already high. That one indicates hypervolemia. Patient volume is adequate. If they cannot have hypertension, so you give the patient with already enough fluid, you give fluid somewhere where it may can cause hypervolemia. So if patient have hypertension, don't give IV albumin. Okay, that one you need to give IV furosemide. Despite if patient have a bit of AKI, treatment is still with furosemide. Okay, because that one will help to control the hypovolemia and will help to control the hypertension. If not sure, then we need to refer to the nephrologist. Okay, next we talk about basically the prednisolone dose, induction dose for first time diagnosed nephrotic syndrome lah. This is just first time, not the relapse, not the relapse treatment. This the first time treatment. You give penicillin. The dosing is 60 mg per meter square per day. So you need to count the BSA. BSA is height in centimeter times weight in kilo, divide by 3,600, and then you square root. Then you get the BSA. You times 60. You get the dose of penicillin per day. So the dosing is OD. Some may give divided dose, like for example BD twice a day. Most of the time we give once a day. Just take it one shot, or you can take one by one and just try to finish it within 5 minutes. Okay, so that one is OD dose. You continue until remission. Then even already remission, you keep the same dose until 4 weeks. Once you 4 weeks, then you change to the remission dose lah. Remission dose is 40 mg per meter square per day, every other day. Okay, and then you continue that for 4 weeks. After that, you start to taper for the next 4 weeks lah. So it's basically 3 months treatments lah for initial diagnosis of nephrotic syndrome. Okay, so how you know patient already pergi remission? So that's why you need to monitor the urine dipstick daily lah. So urine dipstick you do it every day to see the proteinuria, 1+, 2+, 3+, or trace lah. So it need to be traced for 3 consecutive days baru kita cakap dia in remission. So once patient in remission, then you can change the induction dose to remission dose lah. in a relapse patient lah, but in the initial diagnosis management still continue the 60 mg per meter square per day OD until up to 4 weeks 28 days. Okay, so another definition that need to know is what is relapse. Relapse is basically urine proteinuria, urine protein 2 plus or more for 3 consecutive days. That's the definition of relapse. Okay. The definition for steroid resistant: if failure to achieve remission in the first 4 weeks of treatment, that's considered steroid resistant nephrotic syndrome. Some of the steroid resistant, if you give an extra 2 weeks, maybe another 5% of them will respond. Those group categorized as late responder of nephrotic syndrome. This late responder usually have higher risk of becoming steroid resistant later lah. Okay, so nephrologists may extend the treatment to up to 6 weeks. Some of them may try IV methylpred pulses for 3 days and to see the response. If the 3 days is not responsive, then patient is steroid resistant as well. Okay, it depends on the nephrologist. Some may extend the treatment for another 2 weeks, so 6 weeks of initial treatment of the induction, and then some may try 3 days of IV methylpred. Okay, this IV methylpred treatment in the 3 days basically a very high dose, so basically it equals the 28 days of the steroid regime in the induction treatment. Okay, we talk about the relapse. Relapse basically 3 consecutive day of 2 plus urine proteinuria. So infrequent relapse, and then frequent relapse, that's another definition that you need to know. Frequent relapse mean within 6 months of the initial diagnosis there are 2 further relapses. Mean there is one relapse once initial diagnosis of nephrotic syndrome, then the next 6 months patient had first relapse and second relapse. If those relapse happen within 6 months of the diagnosis of nephrotic syndrome, that's another frequent relapse. Okay, or another definition, maybe the few years of nephrotic syndrome, they have 4 relapses within 12 months, that's another frequent relapse. So the treatment for frequent relapse and infrequent relapse are just a bit different lah. So in the infrequent relapse, they give the treatment, your typical induction dose, which is your 60 mg per meter square per day. You continue the until remission. Once remission for 3 days, then you straight away change to the remission dose lah, which is 40 mg per meter square. For 4 weeks, then you stop. Okay, you taper and you stop. Okay, but for frequent relapse, the common one is despite once you change to the remission dose, which is 40 mg per meter square every other day, you may want to taper it over 6 months. That's the old regime lah. But last year there was a new guideline of the nephrotic syndrome, more focusing on the side effect of long-term steroid therapy lah. So they said basically this nephrotic syndrome, 85 to 95% of them will have frequent relapse or relapse. We will relapse at some points lah. So to reduce the burden of the effect of prednisolone, so they're not going to do the 6 month tapering over 6 months and keep at the lowest dose, because they want to reduce the frequency, they want to reduce the usage of long-term steroid therapy. So they're going to change into the usual treatment lah. Basically you give 40 mg per meter square every other day and you taper for the next 1 month, and then after at the end of the remission for 1 month, then you taper for the next few weeks, then starting to off. No need to continue for 6 months because they're gonna relapse anyway. If you give over 6 months, they're still gonna relapse. If you give over 3 months, like the new guidelines say, they're still gonna relapse anyway as well. So to reduce the burden, they change the they already changed the guideline for treatment of frequent relapser. However, if you want to see follow the tapering of the steroid for the frequent relapser, you may still continue for over 6 months lah, unless until the new guideline, new protocol come out, you may follow the old one as well. You may want to you may want to give the new guideline a try as well lah, if you keen to do it. Basically, if already like frequent relapse, the choice is either to not to when patient achieve remission, they want to change to steroid sparing agent faster, like cyclophosphamide or levamisole or any other steroid sparing agent lah. But cyclophosphamide is is within the treatment of the general pediatrician. You still can able to use it without the need to discuss with the pediatric nephrologist lah. Okay, once patient yang baru first time diagnosis nephrotic syndrome, the edema well control, then you don't need, tak perlu tunggu pun sampai patient remission boleh discharge lah. But the main thing to ajar parents dengan patient, parent is monitoring dekat rumah lah. So they need to know how to use that urine dipstick. They need to know the 6 days punya regime, what need to do and all that. So first thing they have to have is kena beli that proteinuria punya kit lah, urine dipstick tu parent kena beli. And then doctors kena ajar urine dipstick tu macam mana nak buat, macam mana nak simpan urine tu. Then once you dapat ajar macam mana nak pakai, ajar macam mana nak interpret lah. So dekat tepi tu ada color coded kan, dia punya 0, trace, 1+, 2+, they are all color coded. Then need to teach parent how to baca the urine dipstick. Okay, once orang dah ajar, dia orang comfortable, you already counter check semua benda. And then the next thing to make sure parent ada buku lah, this buku untuk record the monitoring lah, the urine dipstick. That one buku pertama, buku kedua, buku follow up lah, so that every time diorang datang follow up, you boleh write down, then so that parent boleh ada reference, and then you all pun boleh refer to patient punya buku lah every time datang follow up. So these 2 books they need to have, and then the urine dipstick also they need to belajar. So once they have all those 3 things ready, patient is quite okay to go back lah. Then tak perlu tunggu remission lah. Once the edema better, but once patient still very edematous, most of the time kita keep patient in ward lah. Dan selagi patient edema kuat teruk, I will biasanya continue the pen V until the edema has improved, then you can stop the edema, can stop the pen V. Some may just give their pen V for 10 days and they off, so that one also acceptable. Okay, once you kalau dah discharge, you jumpa balik dia orang 2 minggu dekat appointment clinic, dan you tengok the buku. So make sure the appointment tu still within 28 days lah. So patient 28 days since punya remission, just the main thing is to know patient dah go into remission ke tak lah. Kalau patient still tak go into remission, that's fine, kena refer ke dekat business nephrologist lah. By day 27, day 28, we have to get ready to refer out already lah. Okay, patient yang tengah ada proteinuria or tengah relapse, they have a few risks of complication that can happen. First thing, hypovolemic shock lah. That one is straightforward. So kenapa dia hypovolemic shock? Because of water shifting from the intravascular to intracellular. So that one causing hypovolemia. So the treatments as usual same as hypovolemia. Jangan bagi furosemide lah. You guys can give the volume expander like albumin 5%. And then another common complication is primary peritonitis lah. So another thing we call spontaneous bacterial peritonitis. So this one is can happen because when you have ascites, peritoneum tu is a dependent area. The water will accumulate there, so you have your water is become a medium for the bacteria to grow lah, so they can have infection in the peritoneum, so it become peritonitis. So you might want to give the 3rd generation cephalosporin lah as a treatment of peritonitis. And then another common complication is easily get infection lah. When you have when you lose your protein, one of the protein that you lost is your immunoglobulin lah. Immunoglobulin is the one yang fight off infection. You lost your protector, then you can easily get infection. So you easily can have high grade fever and all that, secondary infection while in ward. Another thing, when in the protein also you lost your coagulation factor, and then you lost your anti-coagulation factor as well, so patient have easily get thrombosis. One of the scariest place to get thrombosis is your brain, so you can get stroke. Another scary place to get thrombosis is your kidney. If you get renal artery thrombosis, you may get AKI lah. Okay. Another important advice untuk bagi tahu parent bila patient nephrotic syndrome yang tengah makan steroid, when diorang ada demam, make sure parents straight away datang pergi hospital straight away lah, jangan tunggu. So because diorang immunocompromised, easily dapat infection teruk. So to save time, tak nak buang masa kat rumah lama-lama, takut kena septic shock yang very bad. So advise parent to come to the hospital straight away, jangan tunggu. Okay. Another general advice we give patient yang on long term steroid, while tengah induction steroid, high dose steroid punya tu, you tak boleh bagi any live vaccine. And then patient kalau ada contact dengan chickenpox punya patient pun, you kena datang hospital straight away. We may give anti chickenpox punya immunoglobulin, give acyclovir or VZIG punya immunoglobulin lah, to fight off the chickenpox punya infection passively. Okay, I think that's all good. Whatever I say is basically just based on my experience. You all need to double check with the protocol, with the guidelines, with the current updates lah. So anyway, don't just take my word for it, you have to double check. So alright, have a good day.